project. Is that how it's supposed to be? I can't hear you. Is that how it's supposed to be?
Yes. There is a background. It says International Colorectal Web Meeting, but the screens are kind of covering that.
Okay.
But we do have a slide as well. Let me get the slide up. Yes. There is a background. It says International Colorectal Web Meeting, but the screens are kind of covering that.
Okay.
Good morning, Ray.
Good morning, Dr. De La Torre. I wasn't ignoring you. I was in the middle of something. So, so you finished the big race. That's fantastic. Congratulations.
Andrea, you said that you sent me the edited PowerPoint.
Yes,
How do you send it?
we transfer.
Hello, Ray.
Ray, do you have the PowerPoint for Dr. De La Torre?
Yes.
The
The
new
one
one?
I sent?
The one you sent, yes.
Can
I
you
found
send
it. I
me
found
Let me
it.
send
I
that.
found
Let me
it.
send.
I found it.
Huh?
I found it. I found it.
Okay, good.
Thank you, Ray. Thank you, Andrea.
Hola, buenos días, ¿me escuchan?
Sí, te escuchamos muy bien, Carla.
Yo no los escucho nada.
Te escuchamos perfectamente, como si estuvieras en la nieve en Denver.
Ella no escucha.
Ah, ok.
Let's put it. Carla.
Dr. Ramaswamy, if you can hear me, can we check your video and audio, please? Perfect.
Good
And we
morning. Can
can't-
you hear me?
Yes, we can. We can hear you perfectly. Thank you very much.
Very happy to see you.
Morning.
Le dirá.
Ah, yo vi está oscuro. Qué raro. Good morning, everyone, and welcome to our International Colorectal web meeting. We have 5 cases today, very interesting ones. And as usual, I just would like to welcome pediatric surgeons from all over the world. So today we have people joining from Bangladesh, Dominican Republic, Mexico, Saudi Arabia, Libya, Morocco, Chile, Russia, Czech Republic, Argentina, Philippines, Oman, and India. I hope I didn't miss anyone. If I did, please type in the chat and we are gonna acknowledge at the end. So the first case will be presented by Dr. Paula Castro Salgado from Colombia. And I just ask all other panelists to please mute your microphone while Dr. Castro is speaking. So welcome, Dr. Castro. You can share your presentation.
Thank you, Dr. Bishop. Good morning for everyone. I'm going to share my screen. Just 1 second. Okay. Can everyone see my presentation?
Yes, it's perfect. Thank you.
Okay. I'm going to present a case of rectal atresia and postoperative stenosis. This is a case from our hospital, Hospital Universitario San Ignacio at Bogotá, Colombia. This is a male patient with a history of abdominal distension and no meconium elimination. He had a normal anus, and at the external exam, a probe was inserted through the anus and only 2 centimeters passed. So he was diagnosed with rectal atresia and underwent diverting colostomy and mucus fistula on the 5th day of life. After that, this is the preoperative distal and proximal colostogram. We can see here and here. Excuse me 1 second. Pointer, okay. We can see here that it shows a blind dilated rectum. And with this, we confirm the diagnosis of rectal atresia. Here's the first question. What would be the ideal approach? Okay, so first, posterior sagittal anorectoplasty. Second, transanal endorectal pull-through. 3, Duhamel procedure. 4, posterior sagittal anorectoplasty with laparotomy or laparoscopy. Or 5, I don't know. Okay. We did a posterior sagittal anorectoplasty at 11 months old and started the dilations 15 days post-op. The first dilation was with metallic dilators with Hegar 7. And at the external evaluation at 25 days post-op, the patient was already at home. We found that it was very difficult to do the dilation. So we suspected that it was an anastomotic structure there. So what would be your plan? First, distal colostogram. B, attempt dilations. C, intervention. D, I don't know. Okay, we did dilations. We decided to do dilations, and the first dilation was done with Hegar number 3 until Hegar number 7. The next dilation was 1 week later with Hegar number 6, from Hegar number 6 to Hegar number 8. 2 weeks later, we tried to do the dilation, but it was not possible to dilate with Hegar number 9. So we left a Foley catheter channeling the anastomosis and then bring back the patient 1 month later to do another dilation. Here we did a dilation with a balloon catheter, and then calibrated the anastomosis with Hagar number 12. 1 month later, we did another dilation and calibrated with Hagar number 14. Between periods, the mom was doing the dilations at home. But 10 days after the last dilation, the patient assisted to the emergency room because he had rectal bleeding. We did a colonoscopy that showed stigma bleeding and stenosis, and we decided to suspend the dilations. This is the picture of under anesthesia exam. This is 11, 12, 13 catheter that shows the stenotic anastomosis, and this is the external aspect of the perineum, showing the stenosis and the anal canal. Okay, so what should we do next? Redo posterior sagittal anorectoplasty, redo posterior sagittal anorectoplasty plus laparotomy, transanal approach, depending on the distal colostogram, or I don't know. Okay, this is the case.
Okay, did you finish, Dr. Castro, or do you have more
Yes.
slides? Perfect. Can you go back to the first distal colostogram? So I just want to comment a few things right there. Perfect. So when you look the image below this one, the one below where your red arrow is, you can see that this seems to be a high rectum, but it seems that you have enough distal bowel for the pull-through based on the two images on the top towards the right side of the screen. So the question is if you're going to be able to reach this pouch from a posterior sagittal approach. You may, but you have to look above the sacrum. So those are technically challenging operations because you have a normal anus, so it's usually short, but you have to open that and do a circular anastomosis with the proximal pouch. Now, one of the points that I want to emphasize is that when we do postoperative anal dilations, we're not dilating a real stricture. We are just avoiding the natural healing process from closing the anus. So I think in this case, since the beginning, it was noticed that this patient had a severe stricture. You even described that you started with a number 3 Hager. You were doing dilations under anesthesia. What happens with dilations of under anesthesia is that there's an over dilation causing tears and then more healing process. So whenever there is a complication, we feel terrible, the surgeon feels terrible, but instead of trying to act, it's better to stop, let the healing process finish on its own, then do a distal colostogram and access what do I have to repair? How much tissue will I have to remove? Do I have enough bowel? And then plan your next step. Because I think trying to rescue an operation that something happened and it didn't go well, we end up causing more damage and more suffering to the patient. So my recommendation would be at this point, wait. Don't do anything. The patient has a stoma. The patient is safe. So wait 3 months or 6 months then repeat the distal colostogram. Then we're gonna see what needs to be done. Is it just redoing that anastomosis, or are we gonna have to go prepare to enter through the abdomen and take down that mucus fistula, because you need a good anastomosis without tension and excellent blood supply. So those would be my comments. Dr. Peña, do you want to comment?
There's no way to show this.
There is, but let me see. Okay,
I want to,
let's see.
no, Mr.
It doesn't,
Is that focus?
no, it's not. Sorry, we're trying, this camera is not. Let me just put,
So-
yeah, unfortunately, here.
No, it's not in focus.
Okay, just
But it-
one
but-
second. Let me just try without. No, unfortunately, we can't. Yeah,
Oh,
it doesn't go. Sorry.
Okay, well, for those who have the book, in page 202 of the book Surgical Treatment of Colorectal for Children, you will find images concerning the repair of rectal atresia. Rectal atresia is a malformation that has an excellent functional prognosis, because those are babies that are born with intact anal canal. The little anus and rectum that they have, is the preservation of that is the key to have bowel control. So those patients deserve extremely careful technique. Now, the little anus is very, very small because it has not been used. And to try to anastomose a dilated rectum from above to that little anus usually ends up with a stricture like the one that you had. So the recommendation is to, when you open posterior sagittal, you open also the little anus like that, and you have to make a plasty to be sure that you make a wide anastomosis, even if you don't respect completely the little anus, because if you try to make the anastomosis in that little anus, it's going to stricture, it's too small, too narrow. In the page 202 of our book, you will find the details of that surgical technique, and that's the key to avoid the strictures. Those patients will need dilatations anyway, as Dr. Bishop said, but not dilatations to take care of the strictures. There is a big debate at present time in the use of dilatations in anorectal malformations, and there are doctors who say that actually babies with anorectal malformations don't need dilatations. Well, here is my comment. If you make anaplasties that look, now we are not talking about rectal atresia, talking about in general. If you make anaplasties that look like a colostomies, then certainly the patient doesn't need dilatations, because you made an awful, terrible, ugly anus that doesn't need dilatations. But if you respect the rules, follow the rules of the anaplasty and make an anus respecting the sphincter mechanism, the patient will need dilatations, because particularly patients that have a good sphincter mechanism, when you do an anaplasty in a patient with a good sphincter mechanism, at the end of the operation, you see that the anus is closed, and it's closed because the sphincter is working. And if you leave it closed, it will heal closed. If you, on the other hand, as I repeat, you make a huge, ugly anus, then it doesn't need dilatations, actually. So I suggest you to take a look to this technique for the next operation. If you are going to reoperate on the patient, you have to make a wide anastomosis, so they can, because that anastomosis is compressed by the sphincter mechanism, and it will heal like that. So, and strict, as Dr. Bishop said, dilatation, we don't use dilatation to deal with the stricture. When the strictures are there, dilatations just make the stricture worse, because every you do dilatation, you break the tissue and heals, produces more fibrosis and more stricture and more dilatations, and it becomes a torture for the patient. That's another thing that some doctors say, that dilatations produce psychological trauma. Yes, they produce psychological trauma when you are doing it in a patient with an already established stricture and you are forcing the dilators, and we never do that.
Any other comments or questions? Thank you, Dr. Castro. This is, yes, go ahead.
Sorry. We were planning to reoperate the patient, but we had the doubt because we don't know if it is necessary to do like a laparotomy to to accomplish like a pull through and to gain some, I don't know, like better vascularization in order to do a better anastomosis. We were thinking about doing a sagittal, a posterior sagittal anorectoplasty again, but that was our question. We don't know which it depends on the colostogram, but
I would
you
start posterior sagittal, and most likely you don't need a laparotomy. In this malformation, there is no need for a laparotomy. But if during the posterior sagittal you have problems, then you can always turn and open the abdomen.
The only thing we recommend waiting at least 3 to 6 months before attempting a reoperation. Otherwise, you find a lot of fibrosis, bleeding. So it's better that the healing process is completed.
Thank you.
Thank you very much. So now we're going to move to the second case that we will present it by Dr. Ramaswamy from Saudi Arabia. Welcome.
Thank you very much, chairpersons and other delegates. Can you hear me? Can you see my slide?
We can hear you and then we can see the slide. Can you put this in the full screen projection without the side thing? So you want a full display? So if you go down to the very bottom, the orange border, there's a little thing that looks like a curtain. If you click on that, that'll expand it out to the full screen.
Are you not seeing the first slide?
We see the first slide. Can you make this full screen though for us, please?
Of course. Is it all right? No?
Well, we can use this. Why don't we go ahead and use this? Can you move the slides ahead?
Is it okay?
Yeah, let's use this version.
This is the second slide. The patient which I am presenting.
Excuse me,
Male.
Dr. Ramos. We're looking at slide number 1. Can you?
Slide number 1, the place.
Ray.
This
Ray,
one. This one.
He needs to enable the editing button at the top on the yellow bar.
Oh, did you hear that? If you go up to the top yellow bar, it says enable editing. Please, you want to select that, please?
I didn't understand. This one?
At the very top, it says protected view. Be careful, files, blah, blah, blah. If you scroll across from that, you'll see something that says enable editing.
Enable editing.
Above your slide, above the logo from the maternity and
Right,
children.
it's just above the logo. Yep.
Above that, I am seeing not the enable editing.
Huh.
I am not seeing here.
Okay.
So it's frozen.
Okay,
not seeing.
so
Can
I'm gonna move to the next case, and then Dr. Ramaswamy, if you want to close it, and then we'll try sharing again.
Okay.
Okay, so just perfect. So Dr. De La Torre will present the next case that it comes from Chile, but he is giving the presentation on behalf of the pediatric surgeons. So welcome, Dr. De La Torre.
So this case is, this patient is from Santiago de Chile. Dr. Karen Morales, Dr. Pamela Briones, and Dr. Mauricio de la Torre. They had this case. They were not able to present the case because they have OR today, but they had many questions about this case, and they want to hear the input from the all the presenters and everyone. So this is a case of a male patient. Currently, he is 1 year and 5 months. On day 2 of life, the diagnosis of imperforate anus was confirmed. This is the X-ray, so you can see the usual, and I want to say the typical image of a patient with low bowel obstruction. It is important to remark here that the spine looks very nice. The sacrum looks normal. They described that the patient had a well-formed perineum, good anal dimple, and they never see meconium in the urine. So the patient was taken to the OR and they create a colostomy and mucous fistula. The workup of this patient was an echocardiogram, which was normal, a lumbar ultrasound with normal conus and not tether cord. The sacral ratio was calculated in 0.88. The abdominal ultrasound showed normal kidneys, but they did a perineal ultrasound. The perineal ultrasound showed a hypoechogenic filiform area projecting towards the base of the penis. The radiological diagnosis was possible remnant of the digestive tract. So I want to explain this image. This is a sagittal view in the ultrasound. This is the bladder. The black area is the bladder. This is the rectum. I want to say this is the rectal pouch. And this area is the hypoechogenic area that they describe like remnant digestive or intestinal remnant structure here. The next step they did was a high pressure distal colostogram. So you can see here the balloon, the traction. I think it was done properly. This clip was placed in the anal dimple, and you can see the rectum or the sigmoid, the distal sigmoid, and then a narrow area, and then something that was filled out with the contrast. In the lateral view, this is a very nice distal colostogram showing the balloon, which was with traction, pressure, and then this filiform area, and this is the structure that was described like remnants of the intestinal tract in this area, and this is the anal dimple. Same image, just with some measure. They described 35 millimeters from the rectal pouch to the BB marker. So the conclusion was the patient had probably a collection that was a fistulized from the rectal pouch or intestinal embryonic remnant. So the patient had a posterior sagittal anorectoplasty on November at 6 months of age. This is the video that they sent to demonstrate the stimulation in the perineum before the sagittal approach. What were the findings during the PSAR? The rectal pouch was found at 3 centimeters from the anal margin. No evidence of urinary fistula. No narrow areas found in the distal bowel. No collection in the area described in the distal colostogram. And they passed 18 French Nelaton catheter proximally, in other words, through the mucous fistula, 10 centimeters, and they didn't find any structure. So it was uneventful anorectoplasty. This is one of the pictures in the PSAR they sent. This is the rectum. You can see here. And they did the anorectoplasty. What was the outcome after this PSAR? So this patient was discharged on postoperative day 5. At 4 weeks after the PSAR, they started anorectal dilation, and they found a structure at 4 centimeters on the digital rectal examination. They were able to pass an 18 French Nelaton catheter. Then they inject saline, and the saline came out through the mucous fistula. Then the patient admits very easy adherent number 16. But based on the digital exam, they did another distal colostogram after the PSAR and before the colostomy closure. As you can see here, this is a very similar image in the from the previous distal colostogram, and then a narrow area, and then the distal bowel that they use for the anorectoplasty and is patent. So they have leakage of the contrast. Same study in the lateral view. So the proximal rectum, the description of the radiologist was the proximal rectum is dilated and has a communication of 3 millimeters to the distal rectum. The distance from the dilated rectum to the anorectoplasty is 36 millimeters. So they did a colonoscopy. And during the colonoscopy, they found at 3 centimeters from the anus, they found a concentric stenosis. So this is the picture of the screen during the colonoscopy. And this is the, let's say, to me is the congenital orifice or the congenital structure area in the rectum. During the colonoscopy, it was unsuccessful dilation with a balloon. So they tried to do a balloon, dilation with a balloon, but this was unsuccessful. Therefore, they performed 2 radiated incisions with a dual knife on the fibrotic wall. So this is the hole. So they did incision in 2 areas. They did a 4 millimeter incision, and they never observed perirectal fat, I think like to prevent perforation of the bowel. And they corroborate a wide lumen after this procedure. This is the video. They are doing the incisions. This is the proximal bowel. So you can see how big was the lumen after the incisions. This is the the proximal colon. So they again did another distal colostogram after the colonoscopy. And the image was again the same. It is a dilated proximal rectum, this narrow area, and the distal bowel with the anoplasty. And this is after, before and after. Before the endoscopic incisions and after the endoscopic incisions. Looks like this is white or whiter versus these pre-endoscopic incisions. So the questions from this group for the audience was, what do you do? Do you perform another colonoscopy and make a more extensive resection of the stenosis of membrane, they call the membrane of the stenosis? B, perform a transanal resection of this circumferential structure? Perform a posterior sagittal approach, dissecting the rectum, the proximal rectum, and do a Heineken-Mikulicz enteroplasty? Or perform a new posterior sagittal anorectoplasty? Okay, the majority said they can do a Heineken-Mikulicz enteroplasty through a posterior sagittal approach or a new PSARC. They really appreciate your feedback, and they are waiting for your feedback about this case, and they will see this video on the Hendon Project webpage.
Thank you, Luis, for this very interesting case. I think it's similar to the first case presented. The big difference is this one didn't have an anus. That's the variations that we see between one case and another. I think a posterior sagittal approach, good vision, removing, then we're gonna solve the problem. This patient already had 2 approaches, and it's still with very impressive radiologic and clinical findings, so it's time to solve the problem. And I think the lesson learned from this case, the first distal colostogram was so beautiful, so well done and impressive that the surgeon should have doubt what they found during the first operation. So that's when you really have to make sure you probe that proximal rectum, pass a Foley, inflate the balloon, pull back, go all the way from the mucus fistula, go from below, go from above, because the radiologic image was very impressive. It's hard to believe that they were unable to see it during the intra-op, during the first operation. So I think that's the lesson from this case.
Yeah. The Luis, can you show the first the colostogram, the first colostogram? So the first thing that we learned from this patient, from this case, the colostogram.
I think this was a big distractor.
Yeah, but the colostogram.
Yeah.
That's right. The first thing that we learn is to confirm and re-emphasize the importance of doing a good colostomy. We don't do sigmoid colostomies. This colostomy was done too distal in the bowel. And that's a major problem when you want to mobilize the rectum. You are interfered by the colostomy. The colostomy, we emphasize, look at that, this is too distal, very short piece of bowel. The colostomy should always be done in the descending colon in order to have the entire sigmoid loop ready for the pull-through. And by doing that, you will never have this problem. Second, as you see in this particular photograph, you can see where the coccyx is, and you can see that the incision will be able to reveal the distal piece of bowel, and then the surgeon should have explore the upper part to be sure that looking for the upper pouch. So it looks like the operation, the posterior sagittal was a rather shy operation, and opening enough, you will be able to see the entire malformation and do the right procedure, which is a wide anastomosis between the upper rectum and the lower ileal pouch. This is a beautiful, unusual malformation. I have never seen one exactly like this, but I have seen variants of this, and the surgeon should be ready to open and explore completely to be sure that he found the upper rectum. Obviously, they only work with the little distal part. And now in the reoperation, again, you have to, I don't go for hemiculics or those things. Open completely, mobilize the upper rectum. Doesn't need much mobilization. Mobilize and make a wide anastomosis, a real wide anastomosis. That's my recommendation. Very interesting case, by the way, and well documented.
Thank you. So thank you very much, Dr. De La Torre, for presenting, and for the group in Chile for sending such a well-documented case. We're gonna now try Dr. Ramaswamy again. Let's see if we can share the presentation slides by slide.
Is it enough like this, or I should open it up?
You have to open up.
Is it now correct?
No, it's not. You have to click on enable editing.
Enable editing is not seen in my screen. Sorry, I am not seeing the enable editing.
Why don't we post one from this side, and Dr. Ramaswamy will be able to
Perfect.
You
So
use
you
that.
can,
Okay. That's accepted. If you can project from your side.
just a second. Yep, here we go. And I'm going to turn the, whoops.
perfect. Go ahead.
Thank you very much. I am glad to present the voyage of a child with intestinal obstruction. My patient is a male patient. He was referred from a general hospital at the 6th day of his life as a possible distal ileal atresia. He was the first child born to a primate, full-term outcome of normal vaginal delivery. The history, the referral letter shows he had emesis, abdominal distension since birth, and he failed to pass meconium. Clinical examination showed distended abdomen. This was the plain X-ray. That is the left side, we are seeing the supine X-ray, and the right side, the erect abdominal scaiogram showing dilated bowel loops and multiple air fluid levels, suggestive of a distal bowel obstruction. What is the possible diagnosis or differential diagnosis? Hirschsprung's disease, B, malrotation, C, ileal atresia, or D, I don't know, but he needs surgery. Now, what was done on this child? He was subjected to emergency laparotomy on the next day. That is on the 6th day, on the 7th day of his life, without any further investigations. The findings were, the surgeon found that the sigmoid colon and the descending colon were markedly dilated, and the rectum also dilated, but not so dilated as the upper sigmoid colon. The small bowel also showed some dilatation. Therefore, the surgeon came to the conclusion that it can be Hirschsprung's disease with the transition zone at the mid-sigmoid, and multiple full thickness biopsies were taken, one from the rectum just above the peritoneal reflection, and the other two from the sigmoid colon just distal to the middle and just proximal to the middle, where macroscopically he found a transition zone. And he divided sigmoid colostomy at the probable transition zone. Next. This child had uneventful postoperative period. The distension subsided. The stoma was viable and functioning and healthy. He passed stools regularly through this sigmoid colostomy, but he developed incisional hernia at the right half of laparotomy wound. That was exploratory laparotomy, right upper transverse laparotomy incision. Incisional hernia developed at the right side, right half of that incision. 1 month postoperatively, the histopathology report was available, and it reported as having normal ganglion cells in all the 3 specimens. What is the next step? Colostomy closure. B, proximal and distal colostogram. C, I don't know. What was done on this child? The surgeon, finding that the histopathology reports are negative for Hirschsprung's disease, his operation findings suggested Hirschsprung's disease, but the reports came negative. He closed the colostomy, and repair of incisional hernia was also done. On postoperative day 5 of this operation, child developed severe abdominal distension. He failed to pass stools. There was bilious nasogastric drainage. The abdomen was very tender with erythema and abdominal wall edema, suggestive of peritonitis. Plain abdominal scaogram showed pneumoperitoneum along with distended bowel loops and air fluid levels. Next, please. That is the X-ray findings. This is the supine X-ray and the erect abdominal scaogram showing the pneumoperitoneum, dilated bowel loops, and the fluid levels. Next. So what was done? Emergency laparotomy was done on the same day. It was found to have a leak at the closure of colostomy site, at its anti-mesenteric site. Also found were malrotated intestines and subhepatic cecum without obstruction of the duodenum. What was done? Repair of the anastomotic disruption, because the surgeon confessed himself that there was a technical fault in the anastomosis. Therefore, he did repair of the anastomotic disruption along with appendicectomy as one of the steps of the treatment of a malrotation of midgut. and insertion of intra-abdominal suction drain. On the third postoperative day of this operation, child recurred to have abdominal distension, partial wound dehiscence, and evidence of fecal fistula. The abdominal drain brought out intestinal contents. Next, please. By finding these, a re-laparotomy was done on the fourth post-operation day of the last operation. The findings were leak from the previous anastomotic site, along with the peritonitis. What was the procedure done? Anastomosis disconnection. Proximal limb was brought as end colostomy, and the distal limb was kept as Hartmann's pouch. There was a minute perforation at the terminal jejunum that was closed. The abdomen was closed using tension switches after putting a drain. In this way, child had a smooth recovery, and after a period of 31 days, he was discharged home with the colostomy. At the age of 1 year, child was called back, and he underwent a transanal full thickness rectal biopsy under general anesthesia. And this biopsy was taken from 1 centimeter above the dentate line upwards. That histopathology report came to have absence of ganglion cells in the submucosal and intermuscular levels. Immunostaining with the calretinin was negative, confirming absence of ganglion cells consistent with Hirschsprung's disease. Next, please. So the final diagnosis is Hirschsprung's disease, very short segment Hirschsprung's disease. What is the surgery of your choice? A. Swenson's operation, B. Soyavi operation, C. Duhamel operation. Next, please. Most have the answer, Swenson's. We did a modified Duhamel's operation, the Martin's modification of Duhamel's operation was done. The sigmoid colon and the rectum distal to the colostomy, which was kept as Hartmann's pouch in the last operation. This was excised up to the level of peritoneal reflection. That stump was closed, and the colon, the proximal sigmoid and the descending colon mobilized, and did a retrorectal pull through, and a coloanal anastomosis was done about 1.5 centimeters above the level of the dentate line. Next slide. This operation was done at the age of 20 months, when the child was 10 kilogram body weight. End-to side coloanal anastomosis was done. Common opposing walls were crushed with the Irani's clamp, because at this time a suitable stapler for this child was not available. I hope everybody knows about this clamp. This clamp was devised by an Indian named Irani. This was used before the time when the stapler was not available. But this clamp was available here. I brought from India. Therefore, we had this clamp. This clamp was applied, and this clamp was auto-released on the 6th postoperative day. Child had a smooth recovery, except for very frequent loose stools, perineal excoriation, and superficial wound infection. The take-home messages from this case, which I can tell you, are in a newborn presenting with lower intestinal obstruction, we should not have a bias that it is ileal atresia or malrotation like this. It can also be Hirschsprung's disease. And distal intestinal obstruction proved by plain abdominal radiograph should undergo a contrast enema X-ray examination to distinguish small intestinal obstruction from colonic obstruction. The small intestinal obstruction will show unused colon, whereas if there is colonic obstruction, it will be evident. The Hirschsprung's disease has its own radiological signs. That and the level of transition zone will be evident. The narrow segment will be available, and the dilated zone will be evident in the enema X-ray examination. Another point, another lesson is that in a suspected case of Hirschsprung's disease, if intra-abdominal biopsy results are negative, we should not stop there. We should not come to a conclusion that it is not a Hirschsprung's disease, but we should do transanal rectal biopsy to exclude Hirschsprung's disease. Thank you very much.
Thank you very much, Dr. Ramaswamy. I think I really want to congratulate you for presenting this case, because we know they happen in many hospitals, but people usually don't like to present cases that didn't go as well as they should. But I think it's important to emphasize the messages. In this case, you clearly stated this patient needed a full thickness rectal biopsy. This patient needed a contrast enema, and those should have been done prior to the first operation, because it should have been suspected that this was a case of distal obstruction. And we know that Hirschsprung disease always starts from the most distal portion. So the gold standard is always a full thickness rectal biopsy done transanally. So thank you for presenting these cases. I think it's hard, but it's important so we all remember the correct steps. Do you want to comment?
Yes, I want to add that to do neonatal surgery in patients with intestinal obstruction, it is very important to have a good pediatric pathologist with experience in Hirschsprung disease. Apparently, you mentioned that the results of the biopsies came back 1 month after surgery, which is absolutely not useful for the case. So you already mentioned a patient, a newborn baby with lower intestinal obstruction is mandatory to have a contrast study done with water-soluble contrast material to rule out colonic atresia, to rule out Hirschsprung disease, and other malformations. So, and then the problems, we don't know why the patient has so many complications, but it's something that has to be reviewed by you in terms of what could have done better to avoid all these complications in this child. Thank you for the presentation.
Dr. De La Torre, do you want to comment?
Yes, so already Dr. Ramaswamy said that we need to take biopsies in patients with low intestinal obstructions, even when they have malrotation, whatever it is. It's very important to rule out Hirschsprung. It's better to have a normal rectal biopsy than the dehiscence and all these catastrophic outcomes. So thank you, doctor. This is very important for everyone to know that they need to take biopsies.
So we are running a little late. So we're going to move to the next case that will be presented by Dr. Carla Santos. And we're going to leave the last case that it was going to be presented by Dr. Giraldo for the next meeting, because we're running out of time. So Dr. Carla Santos, you can go ahead and present your case.
Good morning. Today I will present a 15 years old female with a cloacal anomaly. She had hemivertebra and she had a solitary right kidney. At another institution, she underwent a colostomy at birth and a rectoplasty at 1 year age without correcting two urogenital sinus. And colostomy closure at 18 months. Most of the time, she has urinary continence, but she has fecal incontinence. Eventually, she has scarce menstrual bleeding through the urogenital sinus. This is the perineal appearance before our correction. She had two orifices. The anterior one is urogenital sinus, and the posterior, you can see the anus. In the abdomen, she had a vesicostomy. She has a vesicostomy. In the picture with a Fowler catheter inserted an oblique scar on the left side. This girl has chronic renal failure with a serum creatinine of 5.4 milligrams, and she requires renal replacement therapy and eventually a kidney transplant. The sacral ratio is poor in two projections, AP and lateral. The contrast enema show a large and dilated sigmoid, full of feces. We started a bowel management program with enemas. First, we use small bowel enemas for fecal disimpaction, and later increased to 800 milliliters of saline solution with 20 milliliters of glycerin. The first image, you can see on the left, the colonic fecal impaction, and progressively, you can see the left colon with skin. Then right, you can see the megarectum and small bladder and a structure resembling a very hypertrophic hemiuterus. The right kidney looks normal. The cystogram showed grade 5 vesico-urethral reflux on solitary kidney with an incomplete duplication of the collecting system. The renal scan showed both undilated perfusion and a slow elimination. The urologists performed a cystoscopy and they only visualized the unique orifice on the bladder neck with a small bladder. They don't see a vagina. The urologist service decided to perform a mitral FANOP and bladder augmentation with ureteral reimplantation, solitary right kidney, and closure of vesicostomy. In the same time, we perform a vaginal replacement and neomalone for the treatment of the fecal incontinence. We perform an anterior sagittal approach with chalice shape extension. Before making the incision, the electrostimulation showed very poor contractility with the anus inside the complex. You can see the planed incision here. The depth of this approach was all the way into the peritoneal cavity. We use two catheters on the urogenital sinus, another in the rectum to avoid injury during the section. After the perineal approach, we performed a laparotomy and decided to use a segment of the sigmoid colon for the vaginal replacement. We selected the sigmoid referent bases on the leg of arterial vessels that supply it. In the drawing, you can see the segment that we use to replacement the vagina and how we preserve the arterial irrigation. We shared to hypertrophic hemiuterus, but we could not identify it. Signs, we were leaving the urogenital sinus in touch. We leave it. We could see a right hypertrophic fallopian tube with normal ovary. You can observe here the arterial irrigation and the segment used for replacement. Here we can constructed the end-to-end anastomosis of the sigmoid colon. Here, the urologist performed the ureteral reimplantation with remodeling tapering of the right ureter because of megarectum, the reimplantation of the appendix for the Mitrofanov, and finally perform a bladder augmentation with ileum. Upon completion of the urogenical procedures, we perform with the construction of the new malone, tubularizing the anterior wall of the cecum above the ileocecal valve. A catheter Foley was inserted and anti-reflux mechanism was performed. This is the appearance of the sigmoid used for the vaginal replacement. And on the right, the introplasty after the closure of the perineal body and the incision. This is the final aspect of the hair abdomen. On the right side, superiorly, you can see the new malone. We place it there because we tried to eat to umbilicus. The cecum was tractionated too much and interfered with Mitrofanov. Below the new malone, you can see Mitrofanov, which was placed there because the mesoappendix was short. And to the left of the incision, there is a cystostomy and ureteral catheter brought out together. After this urological reconstruction, she has been listed for adductories, donor kidney transplant because of the lack of compatible living-related donor. Discussion. The optimal repair of cloacal anomaly must be always the simultaneous correction of the urethra, the vaginal, and the rectum. This principle also applies to other variants of anorectal malformation that require a vaginal replacement. Thank you.
Thank you very much, Dr. Santos, for this great case and for the reconstruction. I think there are many ways to go to Rome. So I'm gonna say, if I was facing this child, there are other options that could have been used too, that may have been a little easier, I don't know. So first of all, I would call this a cloacal anomaly with absent vagina, that the surgeon only separated the rectum and left the common channel as urethra, because you kept describing as urogenital sinus, but in reality, she did not have a vagina. So I would say this is a cloaca with an absent vagina. And as you mentioned in the discussion, we firmly believe that the reconstruction for patients with anorectal malformation should happen at one time. That's the easiest. That's when you have the full exposure. In your case, you have a lot of experience, so you were able to preserve the rectum, preserve the urethra, but that's not always an easy path. So Dr. Patankar, I would say at the age that you do the reconstruction, for most of our cloaca patients, we do under 1 year of age, we do at 3 months, or that's the time you should reconstruct the vagina. Now, this patient, she did not have bowel control. So one option is to enter posterior sagittally, mobilize the rectum, placed a little more posterior because it was a little anterior, and you can use the distal rectum as the vagina and just bring more proximal colon as the new anus. The reason is this is an easier approach. It doesn't require an anastomosis because this patient ended up with 2 anastomoses, one in the colon and one in the small bowel the bladder augmentation. It worked, that's great. But I think you should have this option for patients that do not have bowel control. So those would be my comments. Do you have any other comments?
Yes, well, it's quite an operation that you did, Carla. Congratulations. And you did not mention how many hours you spent in the operating room doing that. But it was a great big operation. Now, when you started presenting the case, you kept talking about cloaca, in which the surgeons pulled the rectum down and left intact the urogenital sinus. So I kept asking myself, what was the length of the common channel? So the first thing I would do in a case like this would be a cysto and an endoscopy to see where is the vagina connected to the uro. If you mention urogenital sinus, means that there is a common channel that then separates into urethra and vagina. And I never heard that. You never mentioned where was there a vagina? Was there a remnant of vagina? If there was no vagina, then there is no urogenital sinus. It's simply urethra. And if there was a vagina, what did you do with that vagina? I didn't see that. That's my only question. And again, it's a great procedure, and congratulations. You spent, I suppose, like 12 hours in the operating room. I don't know, and very elegant final.
Well, I think Dr. De La Torre, do you want to comment? Anything?
Yeah, there are many questions about the timing when we have to do to repair the vagina in patients with cloaca. And I was answering in the chat that should be done when we do the repair of the cloaca. There is no specific age. So the great opportunity to do the vagina is when you do the repair of the vagina. There are many questions about the age of when to do the vagina or the repair the vagina in patients with cloaca.
Yes,
I
so
don't know if Alberto wants to answer you.
Yeah, for us, when the patient is born, if the patient has a vagina, the patient and a hydrocolpos, the patient will undergo colostomy and hydrocolpos drainage. Once we see that the patient is growing and gaining weight, we are ready to reconstruct the patient. And during the reconstruction, the goal is that a patient with a cloaca will leave the operating room with one hole for the urethra, one hole for the vagina, one hole for the anus, with the three of them. So that's the time in a cloaca, we have to separate the structures. That's the time to reconstruct the vagina. If there is a vagina and we are able to pull it down, great. There is a vagina that requires a partial vaginal replacement, that's the time to do it. If the patient has no vagina, we will see what's the potential for bowel control and determine if we should use the distal rectum or a more proximal segment, sigmoid or descending colon for the neovagina. So we always reconstruct the patient completely early in life. That's our recommendation. I would like to thank you, everyone. We are very late, but it was a great meeting. And we hope to see you again in December. Dr. Carolina Giraldo will present her case in December, and I'm going to actually add a similar one just to show that not all rectoperineal fistulas are simple. Some of them come with a lot of complexity. So we hope to see you all on December 15th. If you would like to send a case, please send them to me and we'll be happy to have your case. Thank you very much and enjoy the rest of your day.